Good evening. Hello, everybody. My name is Judy Peterson. Can everybody hear me all right? No. Okay. I'll get a little closer. How's that? Okay, thank you. My name is Judy Peterson, and I'm the President and CEO of the Visiting Nurse Association. It's my pleasure to welcome you here tonight for this event with Stephen Kiernan. And this event is being sponsored by the Madison-Deane Initiative, MDI. And Madison-Deane Initiative has been working really relentlessly for 17 years to provide inspiration and education to community members and also to healthcare providers about the immense importance and value of end-of-life care. Throughout one of the things that's so remarkable about MDI is that they have, throughout those 17 years, really kept an eye to the future and stayed very relevant. And that is testimony to the founders of MDI, Estelle Deane and Joan Madison. Estelle and Joan, would you stand up so we can thank you for all the work you've done in our community? Thank you. I'd also like to ask the other MDI council members to stand at this point and be recognized. I know you're out there. Oh, they're probably standing up, a lot of them already. Thank you. The VNA and MDI have worked very closely throughout their history, but 2 years ago, MDI became a program of the VNA. And it has just been a wonderful complement to the very extensive services and resources that the VNA provides. We provide hospice and end-of-life care in the community with home visiting, with visits to people in skilled nursing facilities and residential care facilities and other settings. Of course, we have the Vermont Respite House, our inpatient hospice facility, and we provide some other very creative programming such as bereavement groups, Camp Knock Knock, which is a bereavement camp for children and families, and also the Noyana Singers. So there's much work to be done, and we're just so happy to be doing it in conjunction with MDI. As I look around the room, I see many of our partners who have been in this journey with us together. And I want to thank you for your support and collaboration, and also for coming here this evening to be with us. What we're going to do now is go forward with expanding our services and working with those partners, because there's so much more we know that we want to be able to do. And in the past several years, I think you've all heard the mounting discussion about end-of-life care and what is considered a good death, and how do you achieve that? And you hear it from the New York Times to the John Daly Show, from experts to lay people. Everybody wants to know what's a good death and how can we get there. The VNA and Madison-Deane Initiative really applaud that discussion. We want to be part of that discussion. And a little later this evening, after Stephen Kiernan's presentation, I'd like to share with you some plans that we have for the future to really advance that agenda. So at this point, it's time to introduce our very dynamic speaker, who in the tradition of MDI will be providing you with a very thought-provoking presentation. And to introduce Stephen, I'd like to ask Holly Miller to join me at the podium. And the VNA is immensely grateful for Holly, because Holly, as a member of the MDI Council, has just had tremendous energy and provided such support for education and access to end-of-life services. Please welcome Holly Miller.
It's a little nerve-wracking to say things about Stephen, in that he's a wonderful writer, and writing a piece to say about him is very difficult for me, but I'm really privileged to do this. So on behalf of the Madison-Deane, the VNA's Madison-Deane, I'm delighted to welcome Stephen back. He's our friend and colleague, and I think most of you know him or know of him. For those of you who might not know, he's a best-selling author of 3 books and an award-winning journalist and medical reporter. And during his career of more than 20 years, he's written for the Burlington Free Press, the Boston Globe, and many other newspapers and magazines, and has won more than 40 awards in the field of investigative reporting and journalism. Stephen traveled extensively around the country in preparation for his 2006 book, Last Rites: Rescuing the End of Life from the Medical System. Reinforced by medical research and personal narratives, his inspiring and heartbreaking stories of how people are dying make it clear that if we truly care about the humanity of those most vulnerable among us, we must change America's culture of dying. As he continues to travel around the country speaking about the state of our society's health and wellness, his message always comes from his heart and with deep concern. Whether fiction or nonfiction, Stephen's writing often takes us down a road that diverges either east or west, north or south, right or wrong. But he doesn't just point out what is clearly eroding in our modern society and culture. He shines the light brightly enough for us to find the courage and moral imperative to take another road, the road that might be less traveled. And as Robert Frost wrote, I shall be telling this with a sigh. Somewhere ages and ages hence, 2 roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. Stephen's not here tonight to sell books. He's here to make a difference. For him, this is personal. Vermont is his home, and he's concerned about what kind of care will be available here in Vermont for his loved ones as they age and die. So tonight he's here to challenge us, and I have no doubt that his impassioned message will call us to action of some kind. Welcome, Stephen. Come.
Thank you so much. Let me do this. Thank you so much. Better? Hi. Hello, friends. How completely intimidating it is to see all of you here tonight. I think I just broke that. I did. Can I just give you that? You know, you want to make an omelet, you got to break a couple microphones. You know, I'm looking around who is here tonight, and the sheer number of you blows me away, but it's also who you are. And it is so many people who know more about this than I do. I'm seeing regulators, I'm seeing physicians, I'm seeing nurses, I'm seeing administrators in healthcare, I'm seeing perhaps the people I respect most of all here, the ones who completely dust me in the jiggity jog every year for the respite house. And I would love to flatter myself and think that you're here because of me, but I know better. I think there are a couple of reasons that you're here. One of them is that you received a personal invitation from the force of nature, that is Holly Miller, and who we should recognize for her great support of this project. And the other reason is that you care. You care about the condition of our health institutions, and you care about the kind of medical care that people receive at the most vulnerable time in their lives. And so, with the hopes that my computer behaves, what I'm going to do for the next, maybe it's not going to behave. There we go. What I'm going to do, actually you're really fortunate tonight because I don't have a remote control for my computer, and that means I'm not going to do what I always do, which is cover about 4 miles walking around when I'm talking. I'm going to have to stay put. What I'm going to talk about is the imperative, the urgency that we have to provide hospice care to more Vermonters. I will tell you, I've given about 250 talks about end-of-life care, and most places it's about how to do this, how to give end-of-life care, or how to give good end-of-life care, and that's not the concern I have here. It's about the urgent need to give care, hospice care, to more Vermonters. And we had a little conversation beforehand, the MDI folks, VNA and I, about what the title of this talk would be. And we came up with the title, Now More Than Ever. And I was feeling like that was a pretty good sort of, it's always been important, now it's more important kind of thing. And then my friend Dave Walk pointed out to me that that was the slogan for the re-election in 1972 of Richard M. Nixon. My fellow Americans. You know, people laughed when Nixon said it too. Here's what I'm going to do for the next hour. I'm going to give you more data than you want to hear, and I advise you to ignore it. What it really is to show you that I did a lot of homework, and more even behind this data, and I'm going to try and tell you a story, past, present, and future, and particularly emphasize the future. And where I want to go is to describe a kind of problem that we have here in Vermont, and then I'm going to give you 33 ideas for what we might do about it. Some of those ideas are going to be dumb and wrong, and some might be interesting. And I ask you not to throw away the bad ones too. You know the story of Post-it notes, right? The guy brought it forward in the glue division, and they said, why would people want something that doesn't stay stuck, right? And now it's $1 billion product. Or you know, when Steve Jobs got a tour of the Xerox R&D department, and they showed him this roller ball that people were using to control the copiers, and he said, do you know what you have there? And they said, a roller ball to control the copiers. He said, I gotta go. And he went home and invented the mouse, right? There was a guy in 1984 who went into the R&D department at Kodak, and in 1984 he had invented a 1 megapixel digital camera. And they said, are you kidding? We're in the film business. We're in the printing paper business. No one's gonna want a digital camera. So even the bad ideas sometimes have some value. So if you can be open to those as well as the good ideas. What I want to do first and last is tell you a story. This is a story about Betty Goyette. I only knew her a little bit, but her family sure is friends of mine. She lived here in Burlington. She had 5 kids, married to Arthur. She sang in the choir at Christ the King. She sang Oh Holy Night in the Christmas Midnight Mass. Raised those kids, and there's Arthur in Younger Times. And it was a terrific marriage. In fact, their faith was a big part of their lives, and they did a lot of marriage encounter and marriage renewal type of things over the years. And then it was, you know, the kids were raised into adulthood, and they went off into their lives in various directions, some of them still around here. And then there was a time that she was diagnosed with ovarian cancer. And she actually put up a hell of a fight. It was about 8 years that she battled with that. A bunch of different surgeries, a bunch of different chemo and radiation courses, including an experimental course. And there was a point, and Art was taking care of her all that time, up and down the stairs, absolutely true blue, supportive, devoted, loyal husband. And there's a limit to what someone can do. And so there was a point where hospice became involved, and he was really reluctant. It was a matter of pride for him. And finally, he was hurt. He had hurt his knee going up and down the stairs. He had pneumonia. He was in a bad way. And so hospice stepped in. And she ended up being at the fantastic place over in Williston. Oh, I should say that they were doing fundraising walks when they could. So the 2 of them at that all-night cancer walk. And then there was a time when she wound up in the respite house. But look at how this family responds to her birthday in the respite house. That is not a person who's dying. That's a person who's living. One of the daughters dressed as a clown. I asked her if she would come tonight and dress as a clown. I'm a little disappointed. I thought that outfit would look really good. But she's nonstop with the noisemakers. It really would have been distracting. The point is, this is somebody who is still very much living and having a great emotional, active, engaged family experience. The choir would come and sing to her at the respite house. Just a lot of beautiful things that happened. Later in her illness, she was sleeping just about all the time, and it was Art and Betty's 45th wedding anniversary, and Art was giving her 45 kisses, 1 for each year, and they were not little pecks on the cheek. And there was one point where one of the kids walked into the room and said, what's happening? And Art said, oh, now I've lost count. I need to start over. And Betty smiled. Now, if we could pick for the people we love, the last chapter, wouldn't this be it? Isn't this the goal that we have for everyone that we love, for the people that we care for our neighbors, for ourselves? I would submit even for the people we don't like. Isn't it what we would want them to have at the end? This is what is possible. This story is true and real and happened here. Very important to remember. Not a fiction. We are not going to be able to avoid immortality. We're not going to be able to avoid the needs that we have as people who are dying. We're not going to be able to avoid loss. But that doesn't mean that all kinds of good things can't happen along the way, including healing for people on the way to the end of their lives, as they get their affairs in order, as they attain spiritual calm. All kinds of good things are possible. And so what I want to talk about is how we make those things possible in the past, where we are now in terms of making those things possible, why it's urgent that we do better, and ultimately, what kind of things might we do to make it better here? Past, present, future, and big future. So first, with the history. Let me just jump back 100 years and say that 100 years ago, the mortality rate was a lot higher than now. And we had actions by government, by Congress, for example, to protect us, but even down at the municipal level, there were cities and towns that acted. There were vaccines invented that dealt with the primary health scourges of the time. We had public health initiatives like putting iodine in salt, the discovery of penicillin. A lot of sailors and soldiers and airmen came back from the Pacific Theater with malaria. My father among them. He lost half of his teeth before they got it under control. And the CDC was created, pretty much in the headlines now, right? But what they were able to do was eradicate malaria from the United States in 5 years. Blood pressure drugs, new kinds of surgeries. Think of this, in 2 years, 93% reduction in polio. We nailed it. Successful chemotherapy. We had great expansions of access to health care. We had ways to engage and inform the consumer so that they understood that those ads with doctors smoking cigarettes and recommending them might not be the best thing. New York State was the first state to require seatbelts in cars, and in 1984, they were the first state to require people to use those seatbelts. A little bit of a delay, but they figured it out. In October of '73, just about, it might be yesterday was the anniversary of the first test of any EMTs to be certified in the United States, and now there are 940,000 of them, okay? We have lower cholesterol drugs. We have a focus on illnesses that we see with HIV/AIDS, and then you see some of the leading edge medicine that's going on now to the point where we have a bioengineered kidney and the draft of the human genome. Each of these things was the result of somebody who looked at the status quo and the existing health conditions and said, not good enough, I'm going to change something. There's my theme. Not good enough, I'm going to change something. So where are we now? What has this brought us to? I'd say it's a little bit of a good news, bad news, mostly good news situation. First, these are the leading causes of mortality 30 years ago. They were all sudden. Patient would drop dead. A heart attack that was cardiac arrest, stroke and accident. These are the 3 leading causes 30 years ago. And our society mobilized, and in the 30 years since then, we've had dramatic reductions in all 3 of them. 950,000 people survived a heart attack last year, and that's not counting the ones that were prevented. 530,000 people survived a stroke, not counting the ones that were prevented. Unbelievable. Here's the payoff. This is a graph from the most recent issue of The Atlantic, which had the new aging you may have seen. And what it shows is what we have done in life expectancy since 1880. And basically, we're going to go from an average life expectancy of about 40 years in 1880 to a life expectancy of 100 years for someone born in 2080. Here's the number that blows me away. For every year since 1880, we have extended life expectancy in America 3 months. Every year we gain 3 months. Every year, 3 months. Think of that. It's unbelievable. And the only reason the rate is tapering off a little bit in recent years is because we're running out of room to gain on infant mortality because we've gotten so good at preventing it. Otherwise, it would be steady on, 3 months every year. So here's the bad news. Life is still a fatal condition. We're all mortal. I've tried to think of a lot of ways that people have represented this over the years, and I find that the clearest expression of this has really been found by the diligent researchers over at The Onion. And I think that their research is solid enough that we can extrapolate from this to know what's going on today as well. We're all mortal. There's a day every year that is our birthday. There is a day every year we go by without knowing it's waiting for us that is the anniversary of our demise. Right? We are all mortal people. The difference is that today, the leading causes of mortality are all slow. It's a whole different situation. Think of this, just if you want to picture what cancer means in America now, 1 life, every minute, 24/7, 365. In the time I'm talking to you, 60 Americans are going to die of cancer. okay? And they're going to die slowly, typically about 3 years, 8 months from diagnosis to demise, okay? It's slow now. It's a whole different thing. It's a whole different set of requirements. It's a whole different experience. For the patient, there is the terrifying experience of receiving a terminal diagnosis. Didn't used to exist before. For the family, there's this thing of grieving somebody who is still alive right there in front of them and feeling the preciousness of every moment and experience. There are lots and lots of decisions to be made about how much health care to have, how strong to be in interventions, and when enough is enough, and when we need to make comfort the first priority, and so on. Really tough. And for the next about 10 minutes, I'm going to give more of the bad news about this. But I need to preface that bad news by telling you that we now have a problem of success. Because these people who are getting these diagnoses and these family members who are dealing with this, 30 years ago they wouldn't have had that problem because the patient would have been dead. So this is not to beat up on the health system, it's to say that our success has created problems. You didn't need a good bumper in a Model T. But when you're driving a Camaro, maybe you do. So it's a problem of success. And I think the answers, and I don't want to say new answers, but newish answers, are hospice, palliative care, and advanced directives. And I'm going to quantify those things for you in 3 ways. How they're better in quality, how they're better in cost, and what the public wants. And I'm going to share some polling data with you that's proprietary that will tell you what Vermonters actually want from their health system at the end of life, that you're not going to see anyplace else. Let's talk about quality first. Hospice, virtually the eradication of pain for people at the end of their lives. About three-quarters of people complete their lives at home. And it makes possible all kinds of non-medical opportunities, whether it's birthdays, that, like you saw before, or anniversary kisses, or a whole bunch of things I'm going to enumerate a little later. Interestingly enough, people who cease curative treatment and receive hospice care for certain illnesses actually live longer because they're not having the stress of getting dressed and getting to a lab or getting to for a procedure. They're not falling, they're not catching pneumonia, and they actually live, look at this, congestive heart failure, 3 more months, having ceased curative treatment. There's also the experience, by contrast, of what happens for people who are in the ICU. And what you find is about half of the family members of a patient in the ICU are going to have a major life crisis. About half of them, if the relative dies in ICU, are at risk of PTSD. And if they shared in the care decisions of somebody who died, they are 81.8% more likely to experience PTSD. If it's that bad for the family member, imagine what it's like for the patient. By contrast, the national average of satisfaction for family members of people who die in hospice is 86%. A lot better. Now, there have not been enough studies, in my view, of the quality of palliative care, but there was a pretty good one that was done at Mass General. It came out, and this was in JAMA last August. It wasn't a huge study, only 151 patients and not a lot of diversity, but the illness that they studied is the thing that kills more people on Earth than anything else, metastatic non-small cell. That's the biggest killer on the planet. And what they found is for the people who had palliative care rather than the normal care model, there was better communication in all directions. Doctor to patient, nurse to patient, doctor to nurse, spiritual caregiver to family members, among family members, in all directions. In all directions. Half the depression rate, half the pain rate, and about 1/3 fewer people who were receiving chemotherapy at the time of their death. Now, what I think is there were still 33% of these people receiving chemotherapy when they died. What were those oncologists thinking? It's turning around any minute now? I'd say that maybe even in that palliative care model, we could have been more aggressive, but the point is the quality was appreciably and marketably and measurably better. And once again, there was a longevity gain. The people who were in the palliative care group lived about 20% longer than the people that were not in the palliative care group. There comes a point in advanced illness when comfort matters more than the next intervention. And then there's this interesting experiment that's going on in La Crosse, Wisconsin. I'm going to be talking about a bunch tonight. But they decided they wanted to get everyone in that community to have an advanced directive, every adult. And they're at about 96%. And for reasons no one can quite figure out, in the time that they've been working on that, life expectancy there has grown and grown, till now the people in La Crosse, life expectancy is a year longer than the national average. I don't know why. I don't know why. There's a great PhD opportunity for somebody who wants to figure that one out. Okay, let's talk about cost, because in America we're used to thinking about better care is going to cost more, right? Let's get that gene therapy, let's get that artificial heart. I think we need to do another CAT scan of that, okay? We're accustomed to thinking about the better model of care costing less, and what I have to tell you tonight is completely un-American. which is that the better quality of care at the end of life costs less. There have been 17 studies of comparing the cost of hospice care to regular care at the end of life. This is just a sample of them. The top one is a Duke University study, and they said that number could be triple if people got into hospice sooner. The largest number of patients involved was the 1995 study. It said for every $1 you spend on hospice, you save Medicare $1.50. It's worth paying attention to since Medicare is now 3% of the GDP, a single government program. Maybe we could save a little money there. Maybe we're going to need to save a little money there. Again, this is the better quality model. Interesting study that was done at Virginia Commonwealth University down in Richmond, where they took literally divided down the hall and divided people who were in end-of-life care there, and they looked at the cost of care for the two sides. And they saw the nurses were going a lot more into the palliative care side, but the patients in palliative care were having a lot fewer scans, tests, and interventions. And at the end of their lives, it turned out that they cost less than half as much. Better care costs less. And if we take a flight back to La Crosse, oh, I'm sorry, no, before we get to La Crosse, study done just down the road. The bean counters at Dartmouth-Hitchcock, the administrative folks, believed that the palliative care program was bleeding money. So they did a study of everyone who had received palliative care there in 2009. Some that were discharged home to hospice, some that got better, and some who died in hospice, and what they in the hospital. And what they found is that after one palliative care intervention, the first consult, the care cost $700 per patient per day. And that consult typically happens 7 days before death. So they were saving $4,900 per patient. Pretty good for better quality. It's a bargain. And then La Crosse, where the fact that every adult has an advance directive means that the end-of-life care costs there 31% below the national average. It is 70% below the average in New York City. And it's about 40% below the average here in Vermont. For better quality, people in more control. Like I said, it's un-American. It's better quality, but it costs less. We spend almost $300 billion on end-of-life care as a country every year. It's a small corner of our enormous healthcare complex. But if everybody had Dartmouth's results, we could save almost $50 billion. If everyone had La Crosse's outcome, $70 billion. Billion here, billion there. Pretty soon you're talking real money. Who knows how much it would be in Vermont. So then we need to think about, what does the public want? Now, I got to say in advance, I'm presenting some polling numbers from people who were asked what they wanted at the end of life, and they were asked these questions when they were hale and hearty and feeling good. So we got to take them with a grain of salt, because we know that people will make a different decision when the rubber meets the road, right? We know that. But here's some interesting polling data. Now, this is the Cabot logo is not up there because I'm here to sell cheese tonight. This is a company, like many Vermont employers, that is profoundly concerned about the increase in costs of the health insurance premiums of their employees, and in this case, the farm families that make the world's best cheddar. So they've been doing a couple of studies to see what they could do to lower costs, and lo and behold, this study they did, this is a classic poll. They had Macro International right here in Burlington do it, 2,000 people, margin of error 4% or so, and what you see is that nobody wants to die in a hospital and nobody wants to die in a nursing home. Nobody. But that's where 72% of Vermonters die. That's where you're going to die. That's where I'm going to die. Even though that's not what we want. Unless, of course, we change something. And then there was a question that was asked about, what do people want from their professional caregivers? See if this reflects your own desires. Tell me the truth. Don't let me be in pain. Remember that I have feelings. Only about a third of people really wanted state-of-the-art care, and a mere 7% said keep me alive as long as possible, which means 93% said that wasn't that important to them. Now, like I said, we got to take it with a grain of salt, because people in the moment will behave differently. But we don't throw out these results altogether. It tells me that the public is ahead of us on this. They're ahead of the health system that we built. They understand that people's lives end slowly now. They've seen it in their family, and their workplace, and their church, and their community. If it's not fast, these were 3 national studies, and they said, this is what we want. If I'm not going to die fast, please do these things. And there's some interesting things for me about this list. The first interesting thing is that nothing on it is grandiose. Nobody's saying I want to walk on the moon. The second thing is that only 2 things on this list are medical. The first 2, pain and breathing. And the third thing is that all the other stuff is not possible if we don't do the medical stuff at a competent level. You know, you try and make peace with somebody when you're in pain. Kind of hard. Think of the toughest person you know and see if they can attain spiritual calm when they can't get a decent breath. Right? Right at the top of the anxiety scale. So the challenge is to make that care at least competent and preferably excellent, so it will make possible all of the non-medical opportunities. I love talking about last wishes. And sometime I'm just going to give a talk in which I get up and talk about people's last wishes for an hour, because they're so wonderful and human. I'll tell you about a guy I knew of, I didn't meet him, but I heard about, who was 29 years old, and he had a very aggressive brain cancer, and he was hospitalized and was going to be hospitalized till the end of his days. And he was a great outdoorsman and had never married, didn't have a family of his own, and his folks were supporting him, and what he really wanted was his lab to be with him, his dog to be with him. And the hospital was concerned about whether it would be unsanitary, whether it would be distraction, whether it would be a mess, how the dog would behave, but they worked it out and they managed to get it so this dog would be in this guy's room with him. And of course it turned out to be the most popular creature in the whole hospital, and everyone had to come by this guy's room to see the dog. And lo and behold, he ended his life with the dog on the bed with him. I know of a guy, a woman who was losing her husband at 40. And they came to what was going to be the final day, and she was not ready to say goodbye. And she had a conversation with the nurse, who allowed her to go into her husband's room. He did not have a roommate. And she undressed, and she climbed into bed with him, and she held him until he had died. And then by agreement with the nurse, she pulled a sheet up, and she hit the call button, and the nurse made note of the time for the death certificate, and then left her in there. And she stayed with that man until the chest cavity grew cold, and then she was ready to let go of him. I know of a woman who was 93. This story was told to me by her grandson. She fell in the Price Chopper parking lot, 93 years old, and so the EMTs put her on a vent. They picked her up and they brought her to Fletcher Allen, where she was put on a vent, and it became time to wean her, because she had an advance directive that said so. The family had a meeting and they said this is what she wanted. And the physician explained, what we're going to do is turn down the oxygen. Nobody pulls any plugs. We turn down the support of oxygen, and we'll give her a little medicine for anxiety, a little medicine for pain, and then we'll take our time. And as we ease it back, if we see any distress or a crease in her forehead, we'll stop. And we'll give her some more medicine for pain and for anxiety, and we'll wait a little while till that takes effect, and we'll dial it back until the machine is not supporting her. And at the end, she may expire right away, she may breathe for a while, or she may recover and go home and live for another day. And we're just going to let nature take its course. And the next morning, everyone's gathered around the bedside, and my friend Tom is holding his grandmother's hand, and everyone's there, and they have a prayer, and they're crying, it's emotional as could be. And they dial it back, and dial it back, and dial it back, and the crease never comes on her forehead. And when they finally remove the tube, and she's breathing on her own, there's sort of this awkward moment where they're all gathered around and don't know quite what to say. Here she is. And excuse me. And after a minute or two, she blinks her eyes open. And she whispers something. What is it, Grandma? And Tom says, what is it? And he leans his ear right down to her, next to her mouth, and she says, margarita. It's a true story. True story. So he had a commuter mug for his coffee, and he rinsed it out, and he went down to a bar, and he got them to make a frozen margarita, and he snuck it back into the hospital. And the nurse was onto what they were doing, and she said, she has not had anything to drink in 3 days. This may not go well. So what they worked out was they dipped a washcloth in the drink and then put it in her mouth, and sure enough, she went to work on it. She put about 2/3 of that thing away. I love this woman. She's great. And Tom told me this story, and I said, this is a fantastic story. I'll be telling it for months. It's so great. How's your grandmother doing now? And he said, oh, she died the next day. Right, but she was alive to the end. And what I want to tell you is that dog in the kid's room, and the margarita story, and the woman who climbed in her bed with her husband, those 3 stories happened in Vermont. They're not made up, they're real, they happened here. Because people were committed to helping someone live as good as they could, as well as they could, for as long as they could. True stories happen right here. So if you add up the hospice and palliative care and advanced directive model, if you look at it from quality, cost, and the public desires, it's self-evident what we need to do in terms of end-of-life care for people. So the question is, how is Vermont doing at this? How are we doing? And I'd say, once again, it's a good news, bad news situation. First of all, let's look at life expectancy, because that's the real measure of the effectiveness of our healthcare system. And the answer is that we're tied for 5th with a bunch of other states. People in Vermont live about 2 years longer than the US life expectancy. And as the national life expectancy rises, so does ours. You see Mississippi, which has got all kinds of health issues that have to do largely with tobacco and obesity, but all kinds, as well as a weak public health system and not a lot of good immunization for kids. And you see the result of it is that the average life expectancy there is in 75 years. Hawaii has the longest. I think it's doubly unfair. First of all, because they live the longest, and second of all, because they're doing it in Hawaii. Not fair. Here are the top 10 causes of mortality. This is 2012 data in Vermont. We were the 14th state. Heart disease has been the top one for about 80 years. We were the 14th state to have the cancer cross, where heart disease has come down and cancer has come up. Of course, the tobacco states were first, then the southern states, and now it's spreading around the country. So we were a 14th state in the country, and then to be a state, and now we're the 14th to have cancer be number one. If you look at this list and you do the math and you take out accidents, stroke, and suicide, and maybe flu, what you find is about 87% of Vermonters die slowly. So we got 10, 12, 13% that die fast. Everybody else, all of us, it's going to be slow. Now this is going to be a little bit more arcane, but I'm going to look at those 10 causes of death for a minute and walk through what's happened in the last 30 years. There's cancer, slow and steady rise, up 18%. Heart disease, down 42%, in part because we've really reduced cardiac arrest, the sudden death, and in part because people are living a lot longer with heart disease. Respiratory disease, we are 13th in the country in the number of adults who smoke, so that's going to keep right on being a problem, the respiratory disease. Accidents were about level, but actually the rest of the country has made more progress, and our accident rate is a little bit high given how little heavy industry we have. Not quite sure what that means. Stroke, look, the sudden cause of mortality, it's down by a third. Alzheimer's disease wasn't even on the radar 30 years ago. It's up 4,100%. Yeah. Yep, that's a long-term care challenge to all of us. Diabetes, particularly because of type 3 obesity, you see what that's doing, up, doing a big business. Suicide up slightly, but there's a little bit under the covers of that that's kind of interesting. Do you know what age cohort, what demographic group is the fastest rising cohort of suicide? Yes, that's right. It's older men with multiple chronic illnesses. So I would argue they're somewhere in that slow dying category, and instead they take a shortcut with a pistol. Parkinson's was another one not on the radar, up 363%. And if you ever wanted to see the value of an older person getting a flu shot, let this chart convince you. 45% reduction in pneumonia and flu. In other words, everything I've been talking about on a national level is happening here. So how do we provide end-of-life care here? We have 13 hospice agencies. We have one inpatient hospice facility, the spectacular Respite House in Williston. And in 2012, we had 1,409 patients receive hospice care out of the 5,200 people who died in this state. What kind of quality are we getting out of our hospices? Well, there isn't a great depth of information about it, but there is the FEHC 17-point survey, and what you find is that Vermont satisfaction results track right with the national average. Given the margin of error and so forth, we're right at the middle of the pack. Okay? What this means is, I think as you go around Vermont, you will see, in general, a high degree of confidence in the hospice organizations, the VNAs of Vermont, that they're really strong and they're respected in their communities. You'll also notice all the time mentions of the Respite House in obituaries. You look at Meredith's in today's Free Press, right? Thanks to the Respite House. It happens all the time. People are grateful for the care that they received, the perfect closure at the end of life. So if our quality is good and our cost is good and our satisfaction is good, what about access? Can you tell I've been setting you up for this question? Can you feel it coming? Do you already know about this, what the answer is on this? Let's talk about access. 28.5% of Vermonters receive hospice care within 6 months of demise. It's not quite half of the national average. Arizona is able to do about twice as many percentage points of people receiving hospice care at the end of life, and the result is that our hospice care utilization ranks 49th in the country. Only Alaska is below us, and obviously they've got lots of care delivery challenges there that are unique to their landscape. 49th. Of the people who do get hospice, let's talk about how long they get it for. The average length of stay in Vermont is 11.5 days. That is half of the national average, which is shamefully low. In Utah, they managed to do triple what we do. And our rank, in terms of length of stay, is 48th lowest in the country. And when I found this out from the Dartmouth Atlas for Healthcare, when I saw these numbers, I believed the Dartmouth Atlas was wrong. And I went to 2 other sources, and they confirmed it. And I still couldn't believe it. And I went to people who are experts in the study of hospice utilization to say, how are they getting it wrong? Because I couldn't believe a state that is the best at well baby visits and immunization, that is one of the best at preventing teen pregnancy, that is one of the best at immunizations, that is one of the best at women getting mammograms at appropriate times and screenings, that there are so many ways that our health system is considered right at the top. How could we be at the bottom when it comes to caring for people at the most vulnerable time in their lives? How could that be? I get to this point and I say, we have to pause. Everybody is here, as I said at the beginning, because at some level we care about our health institutions and the job that they do for Vermonters. So I want to stop for a second and reflect. Because we all have ideas about what we're doing and why it's right and what its purpose is and where we ought to go next. And the result of all of our collective ideas is that we're at the bottom of the pile. And so we have to be willing to ask ourselves, what ideas are we attached to that we're willing to let go of? How are we willing to change? We can stay status quo and it will continue to be what it is. What are we willing to change? And as you ask that question, I'd like to take a little bit deeper look at what's happening in our hospice providing and our palliative providing here in Vermont that maybe will help you, so you can think about what you might want to change. First, Vermont treats a lot more people in hospice who have cancer than the average. And in a way, that's terrific because cancer is something that hospice is really, really good at, really skilled at that. And it skews the numbers a little bit because hospice patients who have cancer are not going to be in hospice as long as people with dementia, as Parkinson's, as ALS, some of these other illnesses. Also, some of our skew in cancer is because we're better than the average in other measures, like what they call ill-defined diagnosis, which means we don't really know what was the cause of death. We're way, way better than the rest of the country in people who die with diagnosed mental disorders, I think partly because of our mental health parity laws and because of our caring for people with mental illness. And we're about the national average for people discharged alive. So let's look at where the care is provided. In Vermont, we're about 50% above the national average in the number of people who get care and the number of days of care that are provided at home. And meanwhile, we're 1/3 of the national average for the amount of hospice care that's provided in a nursing home setting. Well, what does that mean? Think of it this way. If you are a hospice nurse, here are your choices. In case one, you walk down the hallway of a nursing home and you deal with every person in that hallway who needs hospice care. Pretty efficient use of your time. In case two, you start your day out in Burlington, you drive up to South Hero, then you go to Alburgh, then you see somebody in Grand Isle, then you see somebody in North Hero. You spend more time in the car than you do taking care of patients. And it means not an efficient use of your medical expertise. And lots more challenges when it comes to things like prescriptions and administration and so on. There is also the risk that some of the end-of-life care that's going to be delivered in the nursing homes will be less than expert. Not because nursing homes don't mean well, but because every nursing home is struggling to hire and retain sufficient staff with medical training. Right? We know there's a nursing shortage, and that's where it's visited. How does Vermont compare in terms of the number of people per hospice? The answer is, it's like our school system. We got way more small ones. The average American hospice is 58% bigger than ours, and the number of people they deal with every day is 143% more than ours. Small is beautiful, but sometimes bigger is better when it comes to efficiencies. Every one of our hospices has got an executive director, maybe a person who's a chief administrative officer, development officer, payroll, all of those things, right? Lots of redundancies. We already know there isn't a qualitative advantage. We're right at the national average. If we just moved to the national average in terms of people that we serve, we would close or merge 5 of our hospices. Am I advocating this? No. I'm just saying, what are we willing to change? Are we willing to shift things around so that more money goes to patient care rather than to administration? Just a thought. One thing I want to make clear here again, re-emphasize this is not about the quality of care we're providing. It's also not a crisis. And the reason I know is because this is what a crisis looks like. There's nothing I enjoy more than bashing New Jersey. All right, maybe there are 1 or 2 things, but it's right up there, okay? Look at what goes on in New Jersey. The percent of people that per 100,000 that end up in the hospital in the last 6 months of life, they're 50th. The number of days they're in the hospital at the end of life, they're 47th. The percent of those people who end up in the ICU, they're 50th. The number of those people who suffer more than 7 days in the ICU, they're 50th. This is a crisis for two reasons. One is it's a spectacular amount of human suffering. And number two, those hospitals are addicted to that revenue. That is not a zero-sum game. Every person who goes to hospice out of this system, it's out of the pocket of the hospitals. And they are not friends in that state, I will tell you. So we do not have that kind of crisis. We do not have that kind of animosity. We do not have that kind of addiction. But if we're not in a crisis, we're close. If you look at the accountable care organization that is both Fletcher Allen and Dartmouth Hitchcock, a quarter of the costs come from a single diagnosis. Anyone want to guess what that diagnosis is? A quarter of the spending from one diagnosis. End-stage renal disease, right? And we still have about twice as many people receiving chemotherapy and being hospitalized for end-stage cancer than we ought to. So we're close. This is an interesting thing, you know, people have always said X percent of money is spent on people at the end of their lives. You know, you're 80% in the last 6 months and so on. Well, that never did much for me because, of course, people are always sick before they die, right? Or almost always. So that never, but what's interesting to me is who's it spent on? And what this says is if you look at the Medicare, this is a Vermont number from 2010, state study. It says that half the people in Medicare use very little medicine. Give them their prescriptions and on they go. But there are a few people, a small percentage, that use an enormous amount of medicine. Let's put this in human terms. This means there are about 6,000 people in Vermont who cost us $1 billion a year. 6,000 people, $1 billion. That is a human scale problem. 6,000 people is a human scale problem. I can tell you there are people at Fletcher Allen who spend a lot of time thinking about these frequent flyers and these people who have lots of readmissions and what can be done to improve their quality of life and their health status so that they don't drive the meter quite so hard. And if we don't, there's our crisis waiting to happen. Because what happens when 5% becomes 8% or 9%? If all we did was become average, remember like in Lake Wobegon, all the kids are above average. If all we wanted to do was become average, 900 more Vermonters would receive hospice care every year, and our savings would be in the tens of millions of dollars. If all we did was become average. How did we get here? This is going to be brief because it's really theories, but there's some basis for them. As you'll see, how did we get in this situation? You don't become 49th overnight. It takes a bunch of decisions, a bunch of trends, a bunch of policies to reach that place. The first reason is actually because Vermonters don't use much health care. Pretty much across the board, we use less hospitals, less doctor visits, less pain medicine, up and down. One of my brothers is an ER doc, and he loves talking about people walking in and say, geez, it's been hurt, my side's been hurting for a week, I gotta have my appendix out. And he says, well, you know, I'll be the judge of that. And 75 minutes later, the guy's on the table getting his appendix out. Or, you know, I caught my arm in a baler, and it's been bad for a week, and I guess it's pretty swollen and blue. And so, yeah, it's really broken. You know, so the fact is that we have low utilization across the board, including in hospice. There are plenty of folks who tough it out, right? God bless Vermonters. There is also a certain amount of inertia. Let me ask you this. I'm going to assume just because this is kind of a professional audience, I'm going to make the grand assumption that everyone here is insured. If we were America, of course, you folks wouldn't get the vote. You're the uninsured group. That'd be about that many, right? But let me ask you this. How many of you know from your own health insurance plan how much hospice care is covered? 1, 2, 3, 4. This is more than I've ever seen anywhere. You must all work in HR. I have a Chamber of Commerce plan. I get $5,000 of hospice coverage. How much are you covered for advanced care and ICU? Same people know? Again, I'm just your basic small business plan is $1 million. You do not have to be a very sophisticated hospital administrator to see where the incentives lie. Right? Why did Willie Horton rob banks? We have made great progress in medical education, but the fact is there are only 6 medical schools in America that require a student to take a course in end-of-life care. Here, 10 years ago, the people who were being trained to be physicians up the hill in Burlington, they were getting 8 hours out of their 4 years in end-of-life care. Now they have palliative care week. Bravo. And there's a real interest in that. And all I can tell you is that in all of the rest of the developed nations of the world, every person with an MD after their name has had 200 hours of end-of-life care. Okay? I know that every year I speak to the UVM School of Nursing seniors, and this year it happened to be this afternoon, and I was speaking with them earlier, and they were very excited about palliative care because there's a program where some of them can participate in palliative care, and like 40 of them wanted to, and there was an opportunity in that program for 7 to do so, to work with Fletcher Allen's palliative care team. Potential to enlarge that, potential to have greater reliance there, no charge. I'll skip Thomas Jefferson for now. But I do want to tell you about why the medical education thing is so important. Because I believe that, there are jerks in every profession, but the reality is the vast majority of physicians that I've met in my life are really dedicated, they are smarter than me, they are beautifully educated, they are really doing the best they can with 70 things pulling at them in their time. They really mean well. They really do. But the fact is, meaning well is not enough. They did a study at Harvard where they took 500 Harvard MDs and 500 patients, they had them read the charts and say, how long is this patient going to live? And 17% underestimated, 20% got it right, and 63% overestimated on average by a factor of 5. So 2/3 of the docs said, oh, you're going to live for 5 months when the patient lived for a month. You're going to live for 5 weeks, the patient lived for a week. And you would make very different choices with your time if you had a week rather than 5 weeks, wouldn't you? And these are the smartest people who meant well. And they weren't even close. This is why the medical education component is so important. Another reason we got here, I have to say it, we spent 9 years debating in the legislature physician-assisted suicide. It took up all the air in the room. There were lots of other end-of-life policy ideas that were out there, and they got smothered. Interestingly, when this topic was debated in Oregon, there was a simultaneous effort to increase hospice utilization, and it worked. And while Oregon has had this law for 12 years now, 12 and a half years, they also are now like 5th or 6th in the country in hospice utilization. In Vermont, that didn't happen. It was just for assisted suicide without all the other components of it. And it was very controversial, and it took an enormous amount of time. All I can say is, if the amount of money that had been spent on the 2 sides of that debate had been put together, we could have created a professorship in palliative medicine at UVM's College of Medicine. And there'd be a lot more than 7 nurses that would be getting a palliative care experience during their nursing education. It was the wrong question, in my view. There's also other good reasons. This is Governor Shumlin signing the healthcare reform. Again, it has taken up all the oxygen in the administration in terms of, it's a perfectly wonderful thing to be trying to do to make sense out of our health system, to make a system out of our health system with a jury out on how we're going to pay for it all. But the fact is, it's a sincere effort and it takes a lot of room. I've been in legislative committee rooms where they said, we would love to follow that idea in end-of-life care, but the administration says they don't have the bandwidth right now. Legitimate concern, legitimate objection, but it's one of the reasons we are where we are. If we want to lead in certain areas, there has to be a triage. I would argue we've got some cultural problems too. We really are an independent people in Vermont, and it's evident in our health care as well. Right now, we have a major inpatient bed proposal at Fletcher Allen that looks to me from the outside, I can't tell about the cost part of it, but it sure sounds necessary and appropriate. At the same time that we're at, busting at the seams, census, at the respite house, and other people are talking about another inpatient facility over in the Connecticut River Valley. And these organizations, they've had one conversation rather than really close collaboration. And then we see the low hospice utilization in nursing homes. Some of that is because of the reimbursement systems, and some of it is because we're in silos, kind of how we live, how you can not know your next door neighbor for a couple of years. And then there is the silos of our healthcare organizations. This is kind of a complicated chart, but let me tell you what we have here. On the left side is a list of half of the hospice providers in Vermont, and the next slide is the other half. And across the top, we have 3 national organizations that work on end-of-life care issues. The National Hospice and Palliative Care Organization, the National Association of Home Care, and so on. And then the second 3 there, the Joint Commission and so on, those other 3, those are accrediting organizations, okay, that will look at a healthcare institution according to certain standards and say, are you meeting the standards? And what I can tell you is if you make a chart like this in other states, it's full of yeses. You go to Massachusetts, it's all yes, from left to right, top to bottom. And here, what you see is not an aggressive effort to listen and learn from others. And here's the other half. Interestingly, only the for-profit hospice participates in the accreditation process, and that may be because it's multi-state and they have to, I don't know. The point is, not an aggressive effort. We're still in our silos. Okay, if those are some of the reasons that we got there, why is it urgent that we be someplace else? First of all, we know that our population is aging. Now, a few years ago, I gave a talk based just on this slide, this demographic slide, but it was at a convention of funeral home directors, and when I got to this slide, you could just hear them rubbing their hands together. I mean, talk about job security, you know. Here's what we know now: about 10,000 Americans turn 65 every day. The people who get medical care are older and sicker. And you remember I was talking about the cancer cross before, where heart disease is down and cancer is up? There's also the diaper cross. You know about this? There is going to be a day when Kimberly-Clark is making, the baby diaper production is dropping, and adult diaper. Yeah, that's right. That's our future, all right. All of us are going to live to 95 years old. The diaper cross is ahead. Look what's happening to the population of Vermonters over the age of 60. Look at how it's exploding. And the population over 85, it's exploding. We know these things. We know that we used to be, not recently, we're kind of in the middle of the pack for how old our population was relative to the rest of the country. It's going to be much, much higher. But here are some things that are unique to Vermont. One is that, that a lot of rural elders are going to want to stay in their homes, and they're far flung, so that efficiency challenge is going to continue. And about a sixth of them live below 125% of poverty, which means that their care costs are going to fall on the taxpayers. Another reason that it's urgent is the demographics that affect our society also affect the caregivers. There are too few nurses now. We're 14 years away from a complete catastrophe in terms of the number of nurses that we have. We're not even replacing geriatricians at the rate at which they retire. And the answer isn't for us to create a whole bunch of geriatrics residency programs. The answer is that everyone is going to need to know how to provide appropriate care to people in the later phases of their lives. It's also urgent if you care about our academic medical center. You know, somebody once asked me what I think Burlington would be like if we didn't have Fletcher Allen University College of Medicine, and I said, Plattsburgh with better beer. But here's the truth. If you look at population, I mean, this is a very crude measure, but the reality is that we are going to have enormous cost pressures on our academic medical center. We are. And we're not going to fix our healthcare budgets by leaning on the little hospitals. You can take the 5 critical access hospitals, and Fletcher Allen burns through their budgets in 3 weeks. Our model of care is going to have to continue to evolve really aggressively if we're going to keep these extremely valuable institutions. And that part of that is going to have to be a lifelong attention to accountable care. So let's take a look. Let's do a little apples to apples. Our friends down on the Connecticut River and West Lebanon and here, at how many people they have working in the palliative care staff. And if you do that math, what you find is that there are twice as many people working in palliative care at Dartmouth-Hitchcock. And that's not counting a certified residency in palliative care. Twice as many, double the commitment. And in case you think that they're overextended, let me tell you that they are doubling down. They recently announced a $10 million gift. That's half of the money they're going to raise to build a world-class end-of-life care facility, interdisciplinary, that's going to involve home health care and primary care and inpatient care and soup to nuts. That's where they think the future is. And so if you care about our academic medical center, as I do, if you think it's incredibly important, then end-of-life care improvement has got to be a component of it. It's why it's urgent. Then there's the financial impact. You know that the leading cause of personal bankruptcy today is not credit cards, and it's not gotcha mortgages. It's medical bills, and that's true even for people who have insurance. Think about this from an economic competitiveness standpoint. The average car that comes off a conveyor belt at General Motors in Detroit, $1,400 of the sticker price is the cost of the health insurance of the people who built that car. Not true in Germany, not true in Japan, not true in Sweden. It absolutely affects our competitiveness. Starbucks now spends more money on employee benefits than it spends on beans. And it's absolutely imperative from an employer standpoint. Think of this. Most people who die are over 65, which means that their care is paid for by Medicare. But Medicare does not pay the whole bill. In fact, in Vermont, they pay 48% of the bill. So if you have a gallbladder operation that costs $10,000, Medicare pays $4,800. Well, where does the other $5,200 come from? It gets shifted onto the bills of people who have health insurance. Cost shift has been around for a long time. But as you have more people in Medicare, getting more sophisticated and expensive care, the cost shift grows and grows. That's why some years you'll see that health inflation was 3%, but health insurance premiums went up 15%. That's why it happened, because of the Medicare explosion. It is absolutely essential for the strength of our business community that this hidden tax be minimized, which means that the people in Medicare have got to receive appropriate, higher quality, lower cost care. Also, it's urgent because we are not going to be able to spend our way out of this. That's the national debt number I took off the internet 10 days ago, so that second 8 would be a 9. That would be $17,890 billion in national debt. Growing to $2.5 billion a day, I don't think we're going to see a major initiative in healthcare out of Washington in terms of expanding access to end-of-life care. Maybe the most urgent reason of all has nothing to do with money, actually. It has to do with the faith that people have in medicine. You walk into a physician's office and you're told, take off your clothes, and you do it because you trust this person so much, their training and their ethics and their acumen. But there are signals on the left and right that people are losing that faith. There are some people who feel like, look at the available options, and I want to take control. There are some people who say, you can't even conduct this conversation without pushing me toward the grave. And you may side with one of these. You may think that either one of these points of view is right. I happen to reject them both personally, but the point is that that's beginning on the fringe, the signs of a loss of faith. And if we lose the faith that we have in our healthcare system, that could be the most damaging loss of all. So what can we do? All right, I'm done being heavy. Now is when we get the ideas. Now is when we lighten up. Okay, we're through the tunnel. Here come some ideas about what we might do. And I want to give you a metaphor first. 3 years ago, this state had a catastrophe arrive. It did all kinds of destruction as every one of our little mountain area and valleys became a funnel and poured all the water out the middle of the funnel and did millions and millions of dollars worth of damage. And instead of it being a crisis and a catastrophe, I would argue that it was our finest hour. I've been in Vermont since 1978. I cannot think of another time that we mobilized as one, nearly so much. Our finest hour. And the result is a recovery beyond where it was to where it's much better. Waterbury just got voted the best beer city in America. Take that, Plattsburgh. It happens to be so, and 20 great restaurants, and it's absolutely a vibrant place. We built it back better than it was. And what we need to do with end-of-life care in Vermont, we need to Waterbury it. We really do. So here's some ideas. And by the way, we can do this because this is not a partisan issue, because we are all in this together, because our human infrastructure, the people who are providing the care, are dedicated, do deliver a high-quality job, and because the solutions are mostly human scale. You'll see, I'm not going to talk about reinventing the wheel here. First, we ought to bring in some allies. Candace Powell became the head of the hospice organization in Maine when Maine was 50th in the country. Today, they are exactly at the national average. It took them 12 years to do it. We ought to bring her here, buy her a beer in Waterbury, and listen. Bud Hams is one guy who was the medical ethicist for Gunderson Lutheran Health System in La Crosse, Wisconsin. He is the guy who got every adult in that city to sign an advance directive. We need to bring Bud to Vermont. He needs to see the leaves next year. Maybe he skis. If he's in Wisconsin, he's a lousy skier. But we should bring him here and listen to what he has to say. Donna Roberts, there are no pictures of her. Donna Roberts is shy. But Donna Roberts is also CEO of Hospice of the Plains in Colorado, the 4 most rural hospices in America. And somehow she manages to do it and have almost double our utilization rate. We need to bring Donna to Vermont and listen and find out how she does it and what we can learn from her. While we're at it, Arizona, those are the folks that had twice the % of hospice utilization that we do. Let's get the CEO of that hospice here to teach us a few things. Utah, they had 3 times our length of stay. Let's find out how they did it. I guarantee they got everybody enrolled the first day they were referred in hospice, which doesn't happen everywhere in Vermont. Hospice analytics, the greatest nerds I have ever interviewed. This is a guy in Colorado Springs, and all he does all day is play with the Medicare data set. And so he knows so much about utilization here, and he's so wise. The first time I met him, I was consulting for a hospice in Naples, Florida, that was really smart and had enormous resources because of the affluence of that community and who retires there, and they were watching their market share drop like crazy. And I said to Court, the guy who runs it, I said, why is this happening? And he said, well, when they opened, the minorities in that population were 7%, and now they're 57%, and everyone in their marketing brochures is white. Oh, it had nothing to do with the quality of care at all. It had nothing to do with their pharmacy, which is what they thought the problem was. This is a guy we should bring to Vermont and listen to. And then those national organizations that I listed, they all have their strengths and weaknesses. I'm not a great fan of any of them particularly, but they're people that we could learn from. And when you're 49th, use the cheat sheet. Look on the other guy's homework, because they're doing it right. We don't have to invent it. There are a couple other health systems I've run across in my travels that do an amazing job. Baylor, down in Dallas, their palliative care culture has nothing to do with end of life. It is throughout the organization. It starts when you walk in the door and they have a multilingual person to greet you because of the high Latino population there. And it ends with what your bill looks like and how it explains what's on your bill. You can actually understand a bill from them. I know it strains credulity, but it's true. Yakima Valley Memorial Hospital in Washington, they don't believe that they treat patients, they believe they treat the community. And so when they provide bereavement services, for example, doesn't matter if you ever receive care from them or not. It's for the community. So they will have an event when Christmas is coming, how to handle grief through the holidays. Hundreds of people will come. They don't even take the names. They don't care. They don't care if you were part of our hospice system or not. This is the business that we're in. Allentown, Pennsylvania, you may not think of as an enlightened place. Lehigh Valley has an unbelievably cool thing going on there where they have eliminated terminology. They have what they call OASIS. Let's see, it's Optimized Advanced Critical Illness Support. And it is a continuum approach, meaning you're receiving care from them, and there's a day when it's going to be a palliative care person that comes in. They don't say that. They just say, here's somebody who's going to help you with your pain. If it comes time for you to go home to get your affairs in order, they don't say, now we're switching you over to hospice. They just say, this is somebody who's expert in helping you plan for things at home. She's going to teach you how to use an oxygen tank so you don't come back to the ER when you're short of breath. And they're doing a spectacular job. That's a place the Dalai Lama visited because he thought it'd be interesting. There are people we can learn from who are doing great stuff. And these folks, they're getting it done and they're not doing it with a ton of money. Nobody's got a ton of money. Not anymore. There are allies here in Vermont too. You know, can we please have some outreach from the medical community to the Bar Association so that every person who has a will, it becomes a standard that they have a living will as well? Can we do the same thing with life insurance firms? If you're going to plan for a world without you in it, can we plan for the world when you're still in it but near the end of your life? You know, a lot of the disability rights groups were really worked up about physician aid in dying and that legislation because they were worried that, well, for a lot of reasons. And let's just say that they still could be activists in this. For a while, I did a series of talk in VFW halls about the importance of advance directives. And then in the back of the room, there was an attorney and a nurse to help people draw them up. And when I explained about how it would take a burden off of the family of having to make a decision when someone can't speak for themselves, these veterans, they were fantastic. They were like, sign me up, kill me now. They were fantastic. They absolutely got it. And if we want to expand, you know, let's be retail about it. We absolutely have to reach out to the business community because that's who's paying for our health care now, between the premiums of their employees and the cost shift. And by the way, they're the bosses. That's who makes up the boards of our healthcare institutions, our hospitals and nursing homes and home health agencies. We have to engage the business community. They have to understand that this is an economic issue and that their clout needs to be put to use. I'm going to give you an example of one business that did this. Granted, they're caring for people under the age of 65, so it's a small cohort, but check this out. Aetna, one of the largest private insurers in America, tried the compassionate care program. They said we're going to get rid of all the barriers to hospice, we're going to have really aggressive education of the people who are in this pilot project to tell them about what hospice is about, and we're going to have nurses on phones and spectacular support resources for these people. And here's what happened. The percent of people using hospice care doubled, the percent of inpatient days for hospice doubled, outpatient days quadrupled, that's the home visits, quadrupled. The percent of people in ICU stay fell by 2/3. ICU days fell by 2/3, ER visits fell by 2/3. Remember, we saved a pile of money giving people better quality care and, according to polling, what they want by getting the obstacles out of the way. And for a while, Mark Bellini, who's the CEO of Aetna, was talking to all these medical researchers about it, and then he stopped because he realized it was a competitive advantage for his insurance firm. It's like all the other insurers, go ahead and have those obstacles and spend all that money. We're going to have satisfied customers instead. I would argue the faith communities of Vermont have become really way too good at the fancy funeral, and they're not doing enough when the people are still alive. So I would ask you, when you go to your faith community, the next time you go, challenge them. Challenge them to have a hospice volunteer recruitment program. Challenge them to have a special collection for a hospice organization. Challenge them to have every adult in that community write an advance directive. They're great places to lead this. In Indiana, southern Indiana and northern Kentucky, all of the end-of-life care stuff is led by clergy. Most of the referrals are done by clergy, referrals to hospice. Let's engage the faith communities instead of leaving them on the sideline until someone's in a box. Believe it or not, there was an enormous blindness problem in the United States, and it was solved by the Lions Clubs. A while ago, 50 slides ago, I had something about how polio was eradicated basically in 2 years. That was done by Rotary International. They paid for the vaccines and the distribution. These organizations still exist. I'm willing to bet that they have not had somebody reach out to them to say get involved in end-of-life care, not one of them. And I've spoken to a couple of the Rotaries, and they jump at this. They're really interested. They are allies. They're people that could help with this. And then we get to the government. And that's when we start dreaming, right? Because who knows what can be accomplished. It would be wonderful if the federal government would lower the hospice barriers, so you don't have to certify that somebody's within 6 months of demise. So if someone's in a nursing home and they decide that they want hospice care, that the nursing home doesn't stop getting paid. It would be wonderful if we had a federal program to create 100,000 nurses, like in the 1990s we had one to create 100,000 teachers and 100,000 police officers. I don't think it's going to happen. I don't think it's possible. Our legislative branch is too broken. But at the same time, there is something we are going to get from the federal government. Effective January 1st, hospices are going to have to keep all kinds of data on their quality, and that will become public eventually, and so we'll be able to look at a much deeper level at who's doing better than who at what. And this isn't to shame anyone, it's to talk about the opportunity that exists, the capacity for improvement by learning from each other, maybe breaking down the silos a little bit. Now, the state legislatures have done some interesting things in other states. In California, they said, doctors, you can't renew your license until you take a class in pain management. In Ohio, you cannot receive anesthesia unless the hospital has a copy of your advance directive in your file. I don't see our legislature doing this kind of muscular stuff. I don't. It'd be nice if they did, but I don't think it's going to happen for us. So I think we're going to have to look at other ways the government can do this. One of them is we can look through the regulatory process. Like a question in every hospital budget, what are you doing to increase utilization of appropriate end-of-life care and drive costs down? What's your commitment to palliative care? What are you doing with your hospice referrals? And any CON that comes in front of you, now that we know that most people who are in the hospital are older and sicker, what are you going to do to plan for the fact that a bunch of them are going to be dying? Right there in the certificate of need debate. It would be wonderful if we could try the compassionate care idea here in Vermont. And I understand there's an experiment underway involving Blue Cross and the VNA and Fletcher Allen very much in its infancy. So maybe the verdict is out on that, but I'm delighted to see it. It would be great if we could try an experiment here. I would argue if something is 900 people, 900 Vermonters shy of average, that it is a public health issue, just like immunization, just like washing your hands, and that there ought to be a public education process that goes on through the Department of Health, and that the agency, the Department of Aging and Disabilities, also ought to be talking to people about the value of advance directives so that people are in charge at the end of their lives. Of course, it'd be wonderful if we could change the payment system, if we could reward hospice and discourage and palliative care and discourage excessive intervention. And if anybody here has an idea how to do that, please put it in an envelope and mail it to Peter Shumlin. Because it's very, very, very difficult. But there is an interesting experiment that's going on at St. Johnsbury. I'm not a deep student of it, but here's what I understand. That the local hospital, some primary care providers, and the Norris Cotton Cancer Center are working together in concert on a per-patient basis. So they're not getting paid for the transactions and the interventions they have, but more how they take care of each person. And what they're seeing is really high quality, and now some of these physicians' practices are becoming kind of outpatient clinics for palliative care. Very promising. Too early to know how it'll be yet, but it's pretty smart innovation. What can we do as individuals? I hope every one of you has an advance directive. If you don't, you can go to the Vermont Ethics Network website, or you can go to caringinfo.org. You don't need a lawyer. It takes about 10 minutes. Do it with your spouse. You'll be hugging each other afterward. Support hospice organizations, whether that's with a check, or it's with volunteerism, or it's running the jiggity jog. See what you can do to encourage a residency in palliative care at Fletcher Allen. Expand that nursing experience in palliative care. Volunteer in one way or another. You are needed, believe me. What can we do? What are you willing to change? What are you willing to change, having heard those ideas? What if we set some benchmarks? What if we said everyone who's referred to hospice begins their hospice care that same day? What if we said every congregation was working on it? What if every adult had an advance directive and every hospital offered robust palliative care and every nursing home was alive with a hospice agency? What if everyone who wanted to die at home could? What if no one died in pain? What if no one died alone? How do you feel about the fact that today in Vermont, people die alone and in pain? Seems kind of unjust, don't you think? And then you can tell stories. When you have success stories, it's important to share them. You remember the Goyettes I was talking about at the beginning? There's another chapter to that story. 5 years after Betty died, Art met Helene. And it was a whirlwind. And he proposed, and she said yes. And on the Friday of the rehearsal dinner, when they were going to get married, Art had a cardiac event. And he ended up in Fletcher Allen in the cardiac unit. I mean, does this guy lead an interesting life or what? And in the morning, the family was saying, no worries, we called off the caterer, we're going to set aside the cake, we're going to have another day. He said, you are not, I'm getting married today. And there is Art with his nurse, who helped him get in his wedding duds. I love the little white cloth on the table with the heart monitor on it. As he's going down the hall to the waiting room, there's Art with a couple of his daughters. He's smiling like a guy about to get married in the wheelchair there, and he's hooked up. This is Art and Helene exchanging vows. I believe at that particular moment he is putting the ring on her hand. This is Art and Helene and Art's son David wheeling him out after the ceremony, and isn't he a happy guy? Isn't she a happy woman? And they have now been married for 6 years. This is what is possible. This is what is possible. Imagine this. I'm going to use a dark verb in a light way. Imagine if we could metastasize the appropriate end-of-life philosophy and say that pain is essential, and then we see the whole person, not just the illness that's in front of us, that we recognize all the forms that healing takes, that the family gets care, that we all try to be a little less expert, a little bit better at listening. Say we have comfort from the front door to the bill. This story of Art and Betty is real and happened here. It's possible. If it's happened once, it can happen again. So I want to suggest that you think for a moment if there's something that you would change, if there's anything you would change, or if you even just want to continue to be part of a conversation about change. In those little pamphlets that was on every seat, there's a card. If you want to be part of the next step, I don't know what it looks like yet. Maybe nobody fills out a card, maybe everybody does. But if you want to be part of the next step, would you please put a little of information on that? And there's some VNA folks at the door on the way out that you can hand them to, so we can continue this conversation. So it's not just me for an hour, but it's all of your ideas and all of your intelligence and all of your energy. Because I'll tell you, if we can do that, if we can all become activists about this, like they did in Maine to go from last to the middle in 12 years, if we can all take that next step, I promise you, my fellow Americans, that is the way to happily ever after. Thanks. Enjoy, buddy. I was going to take questions for a minute, if you have time.
Yes, I just need to make an announcement.
Okay, feel free. This might.
Of course, Stephen broke the microphone.
Can I use it? Okay, good recovery, thank you. Thank you so much, Stephen, that was great, really wonderful to have you here. We're going to take some questions from the audience for Stephen, but first I'd like to just share a couple of other things with you. Do you remember that earlier I said I wanted to share plans that MDI and the VNA have together for the future? Well, that's what I'd like to do now. As you know, we recognize what Stephen has presented to you today about the low utilization of hospice. We really want to change that. We've tried very hard during these past number of years to try to raise awareness about hospice and palliative care services in Vermont. We've even had a program called Start the Conversation, that some of you may be aware of, where we hold meetings and discussions in towns all throughout the state. But so now we realize that we need to have a deeper understanding, where it seems like something hasn't been working. So I am very happy to announce to you that the Madison-Deane initiative, with the support of the VNAs of Vermont, which is our not-for-profit VNA and home health network that covers the entire state of Vermont, we're working together, and we are commissioning a statewide study to examine end-of-life care in Vermont, and to ultimately inform ourselves about what we can do differently, what changes do we need to make, and certainly we're going to add your, your list to those things. But so this will be very exciting. Kevin Veller is going to be our project manager. Kevin is here in the audience tonight. And we'll be doing discussion groups, focus groups, and studying data around the state with health professionals, community members, and everybody that we can find to really find out, get to the bottom of how can we increase utilization in Vermont of our hospice programs. So that said, now I would also want to say that Kevin is available and other VNA staff. So if you have questions about that hospice study that we'll be launching very soon, we can answer those questions for you after this event. But right now, I'd like to see if anybody has questions for Stephen related to his presentation tonight.
Yes, ma'am.
Between hospice utilization rate and shortage of primary care physicians in Vermont?
That's a great question. The question is there a correlation between low hospice utilization and the shortage of primary care physicians? The honest answer is I don't know. And that's the sort of thing that it would be very interesting to see what this study comes up with. You know, if that's the case, or whether or not that is the case, anyone can make a hospice referral. As I say, there are parts of the country where the hospice referrals come mostly from clergy. Any kind of physician, a nurse, a family member, a social worker, you know, anyone can make that referral. And so it's really more about people understanding that that option exists and thinking about it sooner and being more aggressive about bringing in those resources. Yes, ma'am. Yes.
Have you had an opportunity to do your presentation for the Green Mountain Care Board?
I have not. No.
I think you should.
Well, actually, I know that the chair of the board is here, sitting right in front of me, spitting distance, a poor guy. And I know there were a couple of other, okay, there's another board member, and there were others that were going to come, but the difficulty is if more than two of them are here, then this actually becomes an unwarned meeting of the Green Mountain Care Board. So, so I had conversations with Alan Ramsey and Jessica Holmes separately, and they are very friendly to these ideas, and you know, as you say, I mean, you have the chair of the board here on a weeknight, and someone else on the board here. It says a lot about their interest in this. And you know, when I approached Al about this, his response was, "We shouldn't be last in anything." And I think that's exactly right. There's no reason for it. So I think that you'll find that they care about this too. In addition to the cost components, there's the quality of care issue and what's really appropriate for people.
Any other questions?
Yes, ma'am.
I was going to say, I don't think that's popular knowledge that anybody can refer for hospice. You know, that would be a really quick ad kind of campaign thing. Because I'm a nurse, and I didn't know that anybody could do that, so.
You know, if nothing else I say tonight had any value at all, thank you very much. One more? Yes.
Yeah, we had another question over here.
Yeah,
Yes.
one of your metrics that a lot of this was based on was within a point of demise, and I'm curious about how we measure that.
I'm sorry, I don't understand the question.
One of your metrics about timeliness of referral, I think, into
yes.
palliative care was within 6 months of demise, or it had
Yes.
something to do with the word demise.
Yes.
So I'm wondering how we measure that, how we know that.
Okay, that is a criteria that Medicare looks at in its utilization data, is they say what % of people received any hospice care whatsoever in the last 6 months of life. To me, it was the most inclusive definition. There's some that it's like, you know, how many people died in hospice care with the death certificate signed by a hospice worker, but I wanted to be as generous as possible with it because I felt like it was kind of tough news anyway. I wanted to really make it feel like I wasn't trying to make it any worse than it was, but really just to say, if we're as inclusive as possible in the last 6 months of life, did these people receive any hospice care at all? I think we're probably good on questions.
And I'd like to have Peg Maffett come up
Okay.
from MDI also. Here you go, Peg.
Stephen, we want to thank you for this provoking presentation today, thought-provoking presentation, and your commitment to palliative and hospice care around Vermont and around the country. You have made a huge difference, and we as MDI are proud to call you our friend, and you have helped us making inroads into helping people die well here at Vermont. So I thank you so much.
Totally my pleasure.
And I thank all of you.
Thanks.
And I'd like to thank all of you for coming tonight. It truly does take a village to make change, and you are an intricate part of our village. By being here tonight, you are helping us make palliative and hospice care a safe topic to talk with our family about, our friends and our neighbors, and our community. And that is what change is all about. So thank you, safe travel and good health, and I appreciate you coming. Good night.